Hi, everyone. I'm Julia Belluz. I'm Senior Health Correspondent at Vox. Welcome to the Chan Studio. I'm so thrilled to be here today. I'm actually currently at work on a book about nutrition and metabolism that gets into childhood obesity and some of the research that our panelists have undertaken. So it's really an honor to moderate today's panel on childhood obesity. Before I introduce our terrific panelists, I just wanted to lay out a little bit about what we know about the problem, and in particular, the scale of the problem in the US and globally. So I think one of the most important things to appreciate is that, unfortunately, we've seen a worsening over the last half century of childhood obesity, and we haven't seen a turnaround in any country. So childhood obesity has gone from being quite a rare condition to one that now affects 1 in every 13 children globally. That's in high, low, and middle income countries. In the US, the challenge is even more pronounced. In 2018, 1 in 5 kids had obesity in America, as you can see in this chart. And then, of course, the COVID-19 pandemic came along, and as we know, schools were shut down, children weren't going to playgrounds. There have been studies about related changes in behavior and eating patterns, more ultra-processed foods, being more sedentary. And we have some initial evidence that the childhood obesity problem has worsened. So there was a CDC report that found the rate of BMI increase among kids is doubled during the early months of the pandemic, which means they were putting on weight at a much faster rate than previously documented. The change was especially pronounced in kids 6 to 11 years old who already had overweight or obesity. And the US isn't alone here. So we have data from England that mirrors the trends in the US. In England, the National Child Measurement Program reported an increase in obesity prevalence during the first school year of the pandemic from just under 10% to more than 14% among 4 and 5-year-olds. So that's 4 percentage points in 1 year. And just as in the US, we're seeing this kind of stark worsening in disparities. So as you can see on this slide, more than 20% of young children in the most deprived areas have obesity, compared to less than 8% in the least deprived areas, meaning a child has more than double the risk of obesity if she or he is living in the poorest neighborhoods in the UK compared to the wealthiest. And in the next slide, you can see the disparity is widened over time between the most and least deprived neighborhoods. So the gap more than doubled between 2006 and 2020. So needless to say, this is cause for great concern. And because we know, there are many well-documented reasons for that, which the panelists have contributed evidence on. We know childhood obesity is linked, or obesity in general is linked to serious health conditions, high blood pressure, breathing problems, diabetes, anxiety, depression, and that children with obesity are more likely to become adults with obesity and also at a higher risk for these chronic diseases. And I think one really important thing to remember is that alongside these worsening trends, we've learned a lot about what works, about the science of obesity, and this is what we're going to explore today. So we'll talk about some of the latest findings. We're going to explore policy interventions that can make a difference on the community level. Our panelists also have advice for families at home who are thinking about childhood obesity, and many of you thank you so much for participating. You've already sent in questions, and you can continue to do so in the chat box on YouTube, and we'll get to as many questions as we can. So without further ado, I'd love to introduce our panel, starting with Bill Dietz. He's the chair of the Sumner Redstone Global Center for Prevention and Wellness at George Washington University. Sadaf Faruqi, welcome Principal Research Fellow and Professor of Metabolism and Medicine at the University of Cambridge in the UK. Steve Gortmaker is a professor of practice and director of the Childhood Obesity Intervention Cost Effectiveness Study at the Harvard Chan School of Public Health. Saba Khan is director of food pharmacies at the Children's Hospital of Philadelphia, practicing pediatrician and assistant professor of pediatrics at the University of Pennsylvania. So welcome, everyone. Thank you so much for being here. And I think we can dive right in. If it's okay, I was going to start with a question for Bill about some of the environmental drivers of obesity. Bill, if it's possible, could we lay out what is driving the increase, what we know about the contributors to childhood obesity and how that's maybe shifted during the pandemic?
Yes, thank you, Julia. As you mentioned, I think it's important to note that childhood obesity in the US and globally was increasing prior to the pandemic. And the pandemic really unleashed a whole nother range of increases, which are much more dramatic than the increases prior to the pandemic. And as you pointed out, it was particularly a problem in children who already had obesity or were overweight. There was also a much more marked increase in Black children and Hispanic children, and particularly in 6 to 11-year-olds. And in those groups, Hispanics, Blacks, 6 to 11-year-olds, the increases were much greater than they were in any other group in the US pediatric population. And I think there are a variety of reasons to explain what happened during the pandemic, which also may reflect on problems prior to the pandemic. So that, for example, in the US, food access was limited. Schools closed and children relied on schools for healthy meals. We know that from a study that Steve Gortmaker conducted that showed that the Healthy Hunger Free Kids Act, which changed the pattern of foods in schools, had a particularly positive impact on reducing obesity in lower income adolescents. The other thing that schools are responsible for is increasing physical activity. For example, we know that during the summer, when schools are out, physical activity reduces. So I think that combination of reduced access, the elimination of school meals, and the elimination of physical activity in schools were really very important problems associated with the development of obesity. The other thing that I think needs to be documented is that I believe that ultra-processed foods are a significant contributor to obesity. And one of the reasons that we see the disparities in Black and Hispanic children and adolescents is the reliance on corner stores, which are not a good source of healthful foods. But I think that it's likely that the consumption of ultra-processed foods increased during the pandemic, particularly among the poor populations and minority populations.
Among researchers like yourself, is there discussion like flash forward 20, 30 years, or even I guess even not even that far right now? Do we think that these trends are going to improve with the loosening of restrictions, or is this like a generation where there's some discussion, where in 20 or 30 years, we're worried about increases in cancer, diabetes, the other obesity-related chronic diseases that we know about?
Yes, I think both things are true. I think that we don't have representative data from the United States just yet, but I think we're going to see a rapid increase or greater increase when we do have those data available. And what it does portend for the future is a higher prevalence of chronic diseases associated with obesity, like heart disease, like diabetes, like cancers.
Thank you so much. I'd like to turn to Dr. Faruqi about the role genetics plays. So we talked a little bit about the environment as a contributor to childhood obesity, but could you tell me a little bit about the latest of what scientists like yourself are discovering about the genetic contributors? Even, to kind of explain why people in even identical environments have very different body weights.
It's clear that what's changed has been our environment, and the rise in prevalence of obesity is driven by our environment. But people often are surprised to find that underneath that, there's a strong contribution of our genes. And we know that because if we study identical twins, for example, they tend to have very similar body weights as adults, even if they live in a completely different environment. And the way that our genes work is they influence how we respond to our environment. So if you, for example, eat the same as the next person, the amount of weight you gain is strongly influenced by your genes. And that's been shown in very nice studies where the amount of extra calories has been controlled and twins gain very similar amounts of weight, but then we all differ between us. So our genes play a strong role in influencing how much weight we gain when our environment changes.
Got it. Okay. Thank you. And a question I had for Steve on successful strategies. So, what do we know about the childhood obesity strategies that have been most impactful to date? And can you tell us about your findings on what isn't working?
Mm-hmm. Sure. Thank you for that question, Julia. The good news here is that there's strong evidence that some programs and policies implemented in recent years in the United States have helped children maintain a healthy weight, particularly in disadvantaged populations. For example, there's strong evidence that nutritional improvements to the WIC food package led to reduced child obesity risk all over the United States. And as Bill mentioned, there's also really good evidence that implementation of the Healthy Hunger Free Kids Act in 2012, championed by Michelle Obama, led to the improved nutritional quality of school meals, more appropriate portion sizes, and there's good evidence of dropping obesity rates among children from low-income households. So these kind of results indicate that if we can return children to the normal daily environments where they have access to healthy nutrition and physical activity opportunities, we can likely turn around the recent COVID-related obesity increases. I tend to be an optimist there. An important point, however, I think, is that we have to focus on following the science. Just as we need to focus on the science to control the COVID pandemic, for example, by increasing vaccine coverage, we also need to follow the science and focus on implementing strategies where we have strong evidence for effectiveness and cost effectiveness to maintain healthy weights in childhood. And there are many such strategies. You can might want to visit our choices site where to see a number of these highlighted. For example, an excise tax on sugary beverages is one that has been successfully initiated in many cities in the United States, multiple other countries. This strategy is expected to save more in future healthcare costs than it costs to implement, and to improve racial, ethnic, and economic equity. Of course, there are many suggested strategies without strong evidence for impact, but I don't think we need to jump and try lots of unproven strategies. There are plenty of strategies with good evidence right now that can work in both sustaining and implementing and reducing child obesity risk. And I'd emphasize again, if you want to improve health equity, you need effective strategies.
Thank you, Dr. Gormaker. And Dr. Khan, I understand that Philadelphia has taken an innovative approach, combining improvements in parks and bike paths, grocery stores. Can you tell me a little bit about the programs that are being carried out in Philly and the potential for impact there?
Yeah, sure. Thank you, by the way, for the opportunity, and so excited to be with this panel of amazing folks who've been kind of in this space for a while. I think Philly started before the pandemic. Several years ago, 10 years ago, we were really kind of starting with kind of hitting where we were with kind of pediatric obesity, and a lot happened at once. But that's what needed to happen. I think Philly really understood that this effect had to be kind of very community-centered and community-centric. And we had to ask. And so there was a lot of asking of folks to say, what is it you want to see more? What's going to make you go to the park more? What's going to make you not pick up soda off the counter? So there was a lot kind of done, even with strategies such as noticing that takeout is a thing in Philly, as it is in a lot of cities in the United States, and speaking to folks who were the vendors of Chinese food. And actually there was strategies there where there was actually an initiative to get less salt in that food. So there was a lot done. And then, of course, as Bill and others have mentioned, and yourself too, the pandemic hit. And we kind of realized, as Steve has just mentioned, how essential school was. And what was happening in schools was actually lessening some of those disparities with the fact that folks weren't having access to food and having spaces to play, because this is honestly what part of the issue was too, that we did not have in Philadelphia green spaces that were inviting and safe, where folks could feel they could take their kids after school. And so as things are opening up, I think it is a moment to reset and say, where are we at? And again, ask, not assume. And also understand that what we're talking about is health behaviors. Weight is centered around health behaviors. And we've got to now, with what we've learned over the last several years, even with lessons we've learned with kind of disparities and other things that we've kind of learned over these last couple of years, we've got to avoid blame and understand it's an opportunity to talk about healthfulness, togetherness, and understanding there is a lot of common knowledge out there that folks know about globally, but how do we make it matter to them? How do we make them see that this is something that is reachable for their families?
I'm curious in Philly if you had insights into how different partners were brought in to dealing with or coming together to deal with childhood obesity. Like we talk a lot in policy circles about the need to have, cross-sectoral collaboration and cooperation, and it can be very difficult in practice. So I'm curious if you had any insights on tackling the childhood obesity challenge from Philly and how you kind of maybe...
Yes, of course. Thank you for the question. So there was many roundtables done at a kind of local level and folks getting together on a citywide level. And the city really did take this on. The city of Philadelphia, I have to give them credit here. They did bring together community nonprofits, folks in the corporate sector who were also ready to say, how can we be part of this as well? And again, even in the last several years, and I can actually speak to a food as medicine program or several food as medicine programs that we've started at our institution. There was a meeting of minds and speaking to folks who were already in this space. So for example, we started a food as medicine program in our healthy weight program, which is our program that's centered around pediatric obesity prevention and management. And that was started again in 2018. But it wasn't that we were trying to reinvent being grocers. We spoke to grocers in the space. We were lucky enough and fortunate enough to actually have a donor who was a grocer in that space, but also met with nonprofits, one of the largest ones in the area, who was already kind of responsible for several food pantries, to ask them what they would want in an ideal world if we were to kind of get involved in this space, and started to talk about food access issues and created a food as medicine program within our obesity program. When things started with the pandemic, we realized that we couldn't close the doors to this and understood it was time to speak to folks who are in the food delivery sector and to see what they could do and what they could do to help us get healthy foods to folks' homes in a social distant, public health guided way. And we found, if you ask, there's plenty of folks who are experts in their space, and understanding that everyone has something to bring to the table, and seeing if we can all kind of then move forward kind of together, and what are kind of shared outcomes and shared metrics that we could follow to really document success and impact.
Very interesting. Thank you. And Dr. Gortmaker, you and others have mentioned the importance of school closures in contributing to this uptick we've seen in childhood obesity. And I'm wondering, on this policy solution side, what schools can do to help children maintain a healthy weight? What should, if you were policy czar for the day and had to mandate what was going to be carried out at schools around the world, let's not stop in America, what would you want to see happen?
Yeah, thanks for the question. I think first, and that's true just about everywhere, we have to work to control pandemic risk through effective strategies like increased vaccination coverage where it's possible, improve school ventilation so that schools can stay open. I think that's the first thing. Then we've talked about the fact that schools are really major sites for healthy nutrition and physical activity among children. And there are a range of things that can happen there where these can be improved even further. In the nutrition area, for example, we can increase access to chilled water dispensers on school lunch lines, make sure that water is available for children, increase physical activity opportunities, active physical education, active recess, lots of opportunities like that. These are effective strategies that have been implemented in different parts of the United States, but really can spread. So I think we can bring children back to these schools that are already there with the healthy nutrition and physical activity opportunities, but then even continue to improve those spaces in those areas. And I think we can create better spaces and more equitable spaces, but it will take effort.
Thank you. I'm curious, just to open it up to all the panelists, and then, we'll go back to other specific questions for each panelist, but several of you have brought up the role of ultra-processed foods in contributing to the problem, and I'm curious what, if any, role you think industry has in ameliorating the trends that we're seeing. The food industry, that's created the ultra-processed foods that we've been that have come up several times. Maybe
Bill has an answer to that one.
I think it's a real challenge. The Partnership for Healthier America, which was started in the Obama administration, has made a number of commitments with industry to increase the access to healthful foods in communities. So, for example, the corner stores were one of those areas, and the food chains that also supply gasoline throughout the country was another target for increasing the access to healthful foods. We know also from communities that a study called the Healthy Community Study, which was published a couple of years ago in the American Journal of Preventive Medicine, looked at the impact of policies related to nutrition and physical activity and gauged their effectiveness or their impact, and showed that in communities with multiple policies of high impact for nutrition and physical activity, the rates of increase in obesity were slower than those in communities that did not have those programs. But one of the concerns was that there was a sample of about 30 of those communities which were minority communities or had high populations of high percentages of minorities, African Americans and Hispanics. And in those communities, there were improvements in the white population, but not the Black or Hispanic populations, which means that we have to think of more relevant or more aggressive strategies. And I think part of those trace back to structural racism. I think that's part of the reason why we don't see grocery stores in lower income communities. And why people in those communities are more reliant on corner stores. And corner stores obviously don't carry the kind of range of healthful products that regular grocery stores do. And I think a second problem is obviously income. The healthier foods, ironically, are more expensive in this country than ultra-processed foods. And what's not to like about ultra-processed foods? They have a long shelf life. They taste good because they're high in sugar, fat, and salt, and they're inexpensive.
Yeah. And convenient, yeah.
And convenient.
Yeah. Yeah, it's a really interesting and challenging problem. And these foods are now so much a part of our lives that, how do you sort of begin to unravel that? And that's fascinating. I think, I'd like to turn a little bit back to Dr. Faruqi about the stigma and weight bias associated with obesity. I understand you've been working with families on this and sort of seeing how stigma and weight bias can affect families and children. And I was curious if you could tell us a little bit about that work and what you've learned about what we should be doing about that.
Yes, so I think, stigma towards children and young people with obesity is really a substantial problem. And in various studies in the US and in many countries around the world, at least 60% of children and young people state that they have experienced bias or discrimination because of their weight. And that really impacts people and young people in many ways. It impacts, of course, their quality of life, their mental health, but also their education and their future life opportunities. And importantly, a lot of that stigma and the bias comes from healthcare professionals. And so that really impacts on how people engage with healthcare professionals. And we know, in fact, that people who score highly on stigma do worse medically or clinically. So they're more likely to gain weight, less likely to lose weight, and they do less well when offered advice from healthcare professionals. So it's a really integral part of our policies and of trying to find ways to tackle childhood obesity is to recognize that this stigma exists and to try to reduce it.
What would you like to tell, like if, I'm sure there are many clinicians in the audience, what would you tell them if they have a child who comes in, with?
I think that the key thing is that, it's really understanding that our biology is strongly linked to our behavior. So we've talked a lot about our behaviors and improving behavior, which of course is key and is vital to any kind of policies that are looking to tackle childhood obesity. But it's about recognizing that it's not all down to self-control and willpower. We are biologically programmed to eat. Our hormones, our genes influence what we eat, how much we eat. A lot of the foods that Bill was referring to, those high-calorie foods that are high in sugar and fat, of course, they're often aggressively advertised, they're easily available and cheaply available, but they're also highly palatable. They ignite parts of our brain that feel pleasure and reward. And so it's nice to eat those foods. That's why people want to eat them. We can test that and show that actually when people don't know what it is that they're eating, those foods will trigger responses in the brain that won't make them eat more. So it's really, I think the message for healthcare professionals is understanding that the reason why some children and young people gain weight more than others is not because they're bad or should be blamed or they should be made to feel guilty, but actually often it's a combination of their social environment, their family circumstances acting on a background of increased genetic risk. And our genes are predisposing us to gain weight because it's a useful thing to be able to do is have extra calories when you may be starving. So it's really understanding that the biology of obesity is complicated and it's not all down to self-control. And I think if we recognize that, that improves the attitude that we have towards the patients that we look after and the communities and the populations whose health we try to improve.
That's such an important point, and one that even in, I think clinician circles isn't well enough appreciated. You almost imagine, do you think it could be useful for clinicians to sort of even lay that out with their patients when they're addressing this?
Sure. I mean, I think that is because, in fact, people know it themselves. People who are really likely to gain weight and struggle with their weight often wonder why it is that they try all these things, they follow the advice, and they find it so hard to lose weight. It's really about recognizing that and saying that the science clearly shows that. And that can really improve the relationship between people that we're trying to look after and healthcare professionals and of course, other members of society, such as teachers. So I think really getting that understanding across is really important.
On the flip side, at least in the US context, I've been hearing about clinicians and other nutrition professionals who say that they almost don't even know how to broach the subject of weight in the context of, anti-fat bias discussions.
So that's got a little bit complicated. Yeah.
That it's become a charged and polarized issue. And so I'm just, I don't know if that's reached the UK as well.
It is beginning to reach the UK. So I think it's really about how you communicate, okay? And it's about being non-judgmental, and it's about being open and having that conversation. And I think it's quite useful to be able to be objective and discuss the science. Now, there is an element whereby, people are beginning to consider that even talking about weight and fat can be stigma, can induce stigma or can actually confer bias. But I think, from purely a health perspective, there's no doubt that obesity is bad for you. There's now no doubt that gaining weight beyond a certain level increases your risks of certain conditions. I think if we can reduce the blame and we can bring science to bear, then we can try and have more productive conversations.
A great point. Thank you. I'm curious, just to go back to Bill, we talked so far a lot about programs in the United States, but as we talked about at the beginning, this is a global problem, and we're seeing increases in childhood obesity in low and middle income countries as well. And I'm curious if you've seen any policy experiments further afield that you think are showing promise, countries or cities that are implementing interesting, or trying to implement interesting solutions to the childhood obesity challenge.
Thanks for that question. Before I answer that, I wanted to just add to Sadaf's comments that physicians are some of the most biased people with respect to obesity. And so it's important for people who treat obesity to be sensitive to their biases and stigma, because they just prolong that exposure. So to return to your question, in 2019, we published the Lancet Commission on Obesity's report entitled The Global Syndemic of Obesity, Undernutrition, and Climate Change. And we argued that these were all interrelated pandemics. We called the climate change a pandemic. And we realized that when we coupled those in time and place, and that there were potentially what we call triple duty solutions, which would address all three of those pandemics simultaneously. So, for example, car use and fossil fuels increase greenhouse gases, which lower the resiliency of crops, particularly in developing countries, both in terms of their yield and micronutrient content. So greenhouse gases contribute to undernutrition in that regard, and that use of cars displaces physical activity, so it has a health impact on obesity. Similarly, on the food side, meat contributes to obesity, generates greenhouse gases, has the same impact on undernutrition. So if we're able to reduce beef consumption, not only do we improve the environment, but we also improve health and nutritional status. So that perspective is really worth thinking about, because the same solutions to climate change also are potential solutions to obesity. And brings to bear some really powerful forces if we can begin to think about those changes as beneficial both for human health and the planet.
Are we seeing, and this can be a question for any panelist or for Bill, if you'd like to answer, are any countries or cities where this is already happening? Are we seeing specific cases?
I should have mentioned that. I'm sorry, I forgot.
Okay, yeah.
Chile, for example, has done a lot in terms of food labeling, and also have completely eliminated the kind of cartoon characters that promote foods for children, like Tony the Tiger no longer exists in Chile. What we know is that that's changed consumption. What we don't yet know is whether that reduces obesity levels in children.
And I've heard that food, the manufacturers of ultra-processed foods have found sneaky ways around the food label, like the marketing and kind of food labeling, like using sugar substitutes and still being able to then market the foods to children because it's not sugar.
Right.
I don't know if this, and I don't know if we have data on that, but it kind of shows, I guess it shows, the scale of the challenge that countries are up against.
Just wanted to kind of add, actually, if I may, there are kind of others in that food spectrum who we can partner with. And while, yes, there's a lot to be done with the food industry, and there's lots, as you said, a lot of sneaky players in there, a lot of grocers are actually trying to be part of the solution. And they understand a lot about their consumer and about health behaviors. And they have been doing a lot even pre-pandemic and now even during the pandemic to get more healthful foods on their shelves. By that I mean a lot of our families who are coming from low-income households are reliant on tinned canned vegetables. So going for canned vegetables that have no sugar, no salt content, are based in water, and putting them at the eye level of folks as they go to get their groceries, and put the higher sugar content ones further up, away from eye level. So they've been doing that and have been starting to partner with it. And so there are kind of, partners out there who are helping become part of the solution to this. So I think there's also a lot in the food access spaces with food pantries, working with programs like Nudges, which are doing a similar thing, get a better lighting in those food pantries, so that we can get, again, those foods we want families to pick up when they're having food access issues on their level, on the shelves that they can reach, and getting those foods that are high in kind of sugar content further away, so it's difficult to kind of get to. So again, doing some more purposeful small things that can maybe shape people making better choices without forcing them to make those choices.
And I guess that's at the level of retailers, grocers, and a lot of the challenge that's been described so far comes from some of the more upstream drivers, like our decisions of what's happening with agriculture and crop subsidies and things like that.
Right. Food as medicine is part of that solution. But again, going with where you're going with this, I think, Julia, is kind of getting our families, but getting our kids. And this was, again, having pre-pandemic, but I think it's really a movement in getting youngsters more familiar with where their food comes from. So there's plenty of schools, plenty of health systems as well that are doing a lot more with farming, even having small farm incentives, allotments on and around their spaces as well. Certainly at the Children's Hospital of Philadelphia, one of our sites actually has a farm and actually has a farmer, a full-time farmer that was before the pandemic and is starting up again, having demonstrations of bringing youngsters from the area, talking to them about the vegetables that we've grown at our health center that season, telling them stories, getting them digging. So I think part of that is, getting our youngsters involved in where their food is coming from.
Yeah, no, that's a great point as well. We've talked so far a lot about, I guess, community and national level policy solutions and approaches. We talked about clinician approaches. Can we talk a little bit about what parents should be doing, like at the individual level, to help their kids stay healthy and to prevent obesity? Maybe we could start with Steve, and if every panelist could chime in. I'm sure many of the parents and caregivers will love to know your advice.
Sure. It's never easy. I know we had twin boys. One thing that you can do is just don't bring sugary beverages home, ever, or virtually ever. Set limits on screen time. That may be something like delay purchasing that smartphone for years. Do things active as a family. Have family meals. I mean, those are a few simple things that families can engage in.
Sabe, do you want to?
Sure. Yeah, I think it's like Steve said, meeting your family where they're at. And I think reassuring the parent that what they can control, or our nutritionist said, and I think you had brought this up, like with especially with some of the points that Sadaf made as well about the stigma, and with the fact that Bill said that the most folks who are bringing the most stigma sometimes into the room are the healthcare providers, is kind of having that conversation, first of all, about talking to them about health behaviors, as we said, but also talking to them about what it is they can kind of control, and talking about what they can provide as opposed to what they are going to deprive. So what a parent can control, our nutritionists always talk about in our weight management program, is a parent can control what food is served, when the food is served, and how the food is served. But what they really are looking for is asking the children to decide how much and whether or not they eat it. And the way you can promote healthfulness is promoting changes in food choices and doing, as Steve had said, as a family, to take on 4 the month of March, we're going to try a new green vegetable at dinner today and at dinner every day. And we can choose who's going to choose that vegetable, but everyone has to at least have one. I always talk about no thank you bite. So even if they don't want another one, they all have to have that bite and they all have to allow it to be on their plate. So small changes like that. And I think it's very important, especially with the pandemic, parents have been much more open to this, for them to become much more vulnerable to the changes they can make too. And how, again, as a family, we can start to make a deal to, along with doing, a movie night once a month, once a week, we're going to start to try an activity together, start to try a gardening activity together. So there's lots of things in that, using that same pandemic, we're in this together. There is a lot that families can kind of start to center their own kind of healthful journey.
It's great point. And this idea of just noticing as a parent how much children are little mirrors for you as well, and trying to model good behavior, which isn't always easy in the environment that we've been talking about. Sadaf, do you have any advice for parents?
I think my colleagues have covered most things. But I think the other key things, are that trying to remain positive and trying to remove blame and guilt from the equation. Because I think certainly when it comes to advice from healthcare professionals, it's often been about banning certain things and removing things. And then when people don't stick to it, or it's because it's hard to stick to it for the reasons that we've said, it makes people feel guilty and then often disengage with the whole thing, or I can't stick to it and therefore, I won't be able to succeed. And the other thing is, within families, recognizing that people have different size appetites. So again, when we tend to give our advice, we tend to give our advice in a very uniform way, because there are some core things that we want to get across. But some people have much bigger appetites than others, and some children will want to eat more than others. And it's about recognizing that and trying to sometimes find some tricks around that, so that you can find other ways of feeling full, or satisfy the child with a larger appetite with foods that are lower in calories but might then fill them up. So I think there are different tips and tricks that people can use, but it's a little bit about recognizing that everybody's a bit different. And of course, many of those differences are down to our genes.
Yes, I know. It was a perfect thing for you to say as a genetics researcher. And Bill, did you have something to add?
I'd just like to recognize Saba's comment, because it was the mantra that we used with families when I was treating obesity. And that is, parents are in charge of what's offered, and children can choose to eat how much. It's not up to the parent to decide that the child should finish what they're eating, or if the child refuses to eat what's served, it's not up to the parent to decide on an alternative. The other two things that I think are worth mentioning is that, in my experience, parents of children with obesity, particularly severe obesity, feel blamed for that problem. And I think we have to come to terms with that, that it's an environmental problem, also an intrafamilial problem, and a complex problem. And then finally, when I was seeing families, one of the critical elements was to make sure that the parents agreed on the solutions, because often there was a real split. And anytime there's a split between the parents about what should be done, nothing gets done. And so it's crucial to establish that agreement between parents. When in my clinic, we used to see at the first visit the entire family to get a sense of that constellation. That's hard to do. I mean, it's hard to get parents together, but the information that we got from that visit was essential to outlining the treatment plan.
In all those patients that you saw and the families that you met, were there patterns that you noticed that are worth speaking?
Many, and I'd be interested in whether this is still the case in Saba's clinic, but severe obesity that I saw was almost inevitably associated with severe family dysfunction. And it's worth mentioning the fact that a variety of adverse childhood experiences contribute to severe obesity in adulthood. And those adverse childhood experiences include things like poverty, racism, family dysfunction, exposure to violence. And although those don't necessarily present as obesity or even, often in severe obesity, but it doesn't necessarily present as obesity in children, it has an impact on adult obesity, where severe obesity is associated with the number of adverse childhood experiences that an individual has been exposed to.
I would agree with you, Bill, and unfortunately it hasn't changed. Those are still the factors that we're seeing in youngsters who have severe obesity. I think it's also something that we kind of emphasize too. We also see the whole family too, and we also try to get all the players in there, even grandparents if we can, because often these families are relying on grandparents for childcare, and that's where like Tommy's spending a lot of his time, and that's where he's getting a lot of his snacks. So it's kind of key to have all the different players in there and get buy-in, and not just get buy-in from the parent, but get buy-in from the youngster. And that can be tough because, again, they have been in this, as Sadafa said, this blame, shame kind of space. So one of the biggest things we start with at the beginning is really talking about BMIs and talking about the physiological outcomes, then the behaviors, and really emphasizing that health isn't a size. Health is something we're trying to get to. And we're not talking about health behaviors, again, are not a weight. And so there's a lot of common ground, and really, really doing our best, if that hopefully family comes back to see us, to celebrate the successes. Even if that success initially is just turning the TV off, sounds small, during dinner time twice a week. That is something. And talking about the fact that we're not looking for 8 weeks and you're going to be a certain size. No, we're looking at a year's time, steps that you have taken as a family to maybe move together, increase your traditions. Your tradition now is, once every week, we always go to the park. That's what the Thomases do. We always go to the park on a Sunday afternoon, and we pack some healthy snacks and have them there. That is a result that family is on a path, and having those conversations with youngsters and the family about what it is they're coming up with on their kind of journey together. And I think that's, again, what the evidence is showing too, that as I think Julia had said, that, our kids so much are looking to us all the time. And unfortunately, parents complain about this. You're never off. If they know that you have a secret stash of soda, they know you have a secret stash of soda. So you're not going to be able to get away with it. You can start to say, I'm going to cut back on my soda the same way I'm going to ask you to come back on the amount of potato chips we have every day, and let's do that together. But you're not going to be able to get away with it if you want this to matter and happen for your family. And look at that young person to make those same choices that you're making now, to hope that when they are a parent themselves, they're going to be able to reinforce the same things that you're talking to them about today.
Thank you, Saba. We've been getting dozens of questions from the audience, both before the event and some are coming through now. So I wanted to turn to those before the time is up. So Griffin asks a question related to what we've been talking about. How do we make physical activity the easy choice in low-income areas, which may not have walkable built environments? Any thoughts on that?
Oh, I think it's a really good question. I would go back first to emphasizing the importance of school settings and school physical activity opportunities, children being able to safely walk to school, being able to have physical education classes, recess. Those are really important opportunities that kids can have in all kinds of settings, as long as their schools have those opportunities. So I think that's one important area to work on.
Thank you. I don't know if any other panelists had anything to add on that.
Well, this has less to do with what parents can do and what communities can do, but the CDC Guide for Community Preventive Services has focused on the importance of community infrastructure as a way of getting kids moving, or at least making it possible for children and adults to move. And that includes sidewalks, crosswalks, pedestrian safety, the availability of physically active transport, meaning bicycles or scooters or walking. And we also know that people who use public transit are much more active than people who don't, because they have to walk to the transit station and then walk from the transit station to wherever their destination is. So long term, those changes in community infrastructure are essential for physical activity.
Got it.
I think I would add that, and again, as Bill had just said, but like better lighting, you know, in parks and things. That's what folks have talked about, that they don't feel kind of safe. And it was so sad, right, in the pandemic, seeing all those playgrounds with yellow tape around them, and not having youngsters kind of play in them. But in that, also realizing, at least when I was on my video visits with families, just how little space there was and that folks had. But even in that space, talking about, at that time, we were talking about having short active breaks, getting them away from screens, 10 to 15 minutes just to kind of increase focus. Again, we talked about in our clinic is, if you don't have the space, is making someone the personal trainer of the week, getting the family involved, and talking about who's going to say do 10 jumping jacks, who's going to, and the kind of family taking that on. Cheap solutions, getting some glow sticks from your kind of nearest dollar store, closing down all the lights in a safe way in a space in the house, and having a 30-minute dance party. So kind of things that get kids excited to move as well, not making it a chore. And again, telling parents to show where they're at too, that everyone's got low motivation right now, and everyone's kind of intimidated by physical activity, and how we can, again, do this together.
Thank you, Saba. Turning back to genetics, we have a question from Jose. Is there a possibility that we are missing a genetic component driving childhood obesity epidemic because of the lack of racial diversity and whole genome association studies?
I don't think we're missing it. I think we know it's there. So we know that 40 to 70% of the variation in weight between two people is due to variation in their genes. And those figures are really across ethnic groups. Now, it's true that actually many of the studies have been done on the genetic factors that influence a person's weight, have mostly been done in people of European ancestry. But increasingly, there are studies that have been done in other ethnic groups. And what they're showing is, broadly speaking, two things. So firstly, there is quite a lot of common ground. So there are many genes that influence weight across all kind of populations, but there are also specific genes that influence both weight and risk of diabetes, for example, in specific populations, such as in people of Mexican ancestry. So for sure, there is always a need for making sure that any genetic studies capture the diversity of the population so that we can learn more. But I think it's we already know quite a bit, to be honest, and it's the same pattern across ethnic groups.
Fascinating. And in terms of the proportion of genes that have been is there a sense of how many more genes associated with obesity that need to be discovered, or like what proportion you found? How much?
So I think there are many more waiting to be discovered.
Yeah,
I guess there's probably two key principles to get across. So one is that in children who gain weight at a very young age, and that's before the age of 5, okay, there we're really looking at, quite often genes have a major role to play. There's a particular gene, sometimes one gene, that's not working very well, and that will tend to manifest before the child is 5 years old. And that will be the same whether the child is in the US or in the UK or in Sudan or in Thailand. Those children tend to become very heavy because a particular important gene is not working. Now, those conditions are relatively rare. They're not as rare as people used to think. They're probably affecting at least 5% of the population of children who are heavy. But in the rest of us, who most people, some people gain weight in adulthood. Some people can eat what they like and they don't put on weight, and some people gain a lot of weight after pregnancy. Those differences between us are down to a collection, thousands of genes, which add up together and contribute to someone's risk. And of course, the people who can eat what they like and they don't gain weight, they also have genes that contribute to their thinness. So yes, there are many more genes to find, but we already know quite a bit about the genetic contribution.
Fascinating. Thank you. So we have a question from Lorena about what are we doing and what can we do about the health disparities that Latino Hispanic children are experiencing when it comes to childhood obesity. We had a lot of questions like this, given the racial inequalities with obesity and other health-related issues. How would you target your response to communities of color? The second one was from Frederick. Maybe if we could start with Steve, if he has ideas on, we talked a lot about how certain communities are disproportionately affected and how do you target these communities?
Sure. Well, I think the first thing you have to think of is that if you want to make a difference and improve health equity, reduce disparities, you need effective strategies. And we've mentioned a few of those that have been shown to be effective. And I think we have to think about, well, how can they be implemented in the communities at risk? And there's a long history, for example, of children being subjected to marketing of unhealthy foods and beverages across the United States, with specific targeting of racial and ethnic minority populations. I mean, this is a tough one. It used to be that a lot of this marketing came through TVs. Now it comes through lots of different screens. And this is a difficult area for intervention, but one thing that could be done is to start to reduce that marketing. Now, currently, we have a tax subsidy in the US for advertising unhealthy foods and beverages to children. This can be changed. A number of the interventions we talked about before can be strengthened in how those interventions are focused on communities at risk. Make sure that school systems are functioning well and have healthy foods and beverages available. Make sure that kids have the opportunities for physical activity, opportunities in schools, in communities. You just have to start to target those interventions with known effectiveness to make sure that they're implemented in communities of color or low-income communities, including the Latinx communities.
Thank you. Was this something any of the other panelists wanted to tackle?
Well, as I mentioned, I think that many of those disparities are attributable to structural racism. That in Washington, D.C., for example, in the two wards which have the highest frequency of African-American populations, those are also those wards which have least access to healthy foods. They are the more dangerous wards with parks that are there but not utilized because of concerns about safety. Those are the deeper drivers, I think, that we need to address.
So far, we've talked a lot about, the familial level interventions that we can do, the modeling as parents and communities, improvements in the schools, but there are a lot of, structural contributors that seem to be, a massive influence on these increasing rates of obesity we're seeing, the structural racism, the built environment in different communities. I don't think we broached this, but I remember coming across a lot of data on low maternal education and the link to obesity, childhood adverse experiences, the stigma that children face not only in their schools and communities, but in their doctors' offices. So it's a multifaceted, complex topic. And thank you so much for walking through the various nuances and challenges that we have to face as individuals and societies. I want to thank you so much for engaging. It's always funny to do it over Zoom. It would be much more fun to do it in person, but hopefully soon. And for the audience, if you missed any part of the program, you can see You can view it on demand at the Harvard Chan YouTube channel. So thank you so much for joining us today. And yeah, hopefully next time we meet, we can, instead of talking about the terrible trends that we've seen since COVID, we can talk about how they're turning around. Thank you so much.